Hi, everyone. My name is Einat, and I'm the founder of Shir for Life, a nonprofit organization dedicated to changing the fate of children with neuroblastoma. I started Shir for Life after my youngest son, Shir, passed away following a year-long battle with neuroblastoma. He was only 2 years old. As a parent, navigating the journey of trying to save my little boy's life, I constantly wished for access to as much information as possible. Navigating this journey is incredibly difficult and affects every aspect of our lives and the lives of our family members. After the initial shock of learning your son has cancer, parents are faced with the challenge of making countless decisions, often without having all the necessary information to make the best ones. This is why I launched this monthly series of webinars. Each session features an expert in the field, dedicated individuals who devoted their lives to changing the reality of children with neuroblastoma. Month after month, we'll hear from the leading professionals and gain valuable information about neuroblastoma. I'm excited that you are all here with us today for this important conversation. These webinars also provide an opportunity to ask questions which we will address at the end of each session. We are thrilled to have Dr. Bagatell here today with us to share her invaluable expertise. Dr. Bagatell is a distinguished pediatric oncologist from CHOP, the Children's Hospital of Philadelphia. Her exceptional contribution to the field have earned her with the widespread recognition, including the CHOP Hematology Oncology Fellowship Award, highlighting her excellence both as clinician and a teacher. Dr. Bagatell has made significant contribution to improving treatment and outcome for patients with high-risk neuroblastoma, refractory and relapsed neuroblastoma. Since 2019, she has served as the chair of the Children's Oncology Group, leading efforts to advance research and care for children with cancer. Dr. Bagatell, it is an absolute privilege to have you here with us today, and I look forward for your presentation. Thank you.
Thank you so much, Einat, for that nice introduction and also for the invitation to speak today. It's my pleasure always to speak with parents and family members and others who care about children with neuroblastoma, because I think that the more we learn about this disease as a community together, the better we can think about treatments and how to make outcomes better for everyone. I'll just share my slides. Here it is. Okay, and here we go. So I'm here today as the chair of the Children's Oncology Group Neuroblastoma Committee. And I know that many of you are very familiar with the Children's Oncology Group, but because this is an international webinar, I just wanted to make sure that everybody was starting from the same place. So I'll spend a few minutes just talking about really what is COG and a little bit also about what we do well and what some of the challenges are for the Children's Oncology Group, which may be the same as some other groups, but different certainly from some of the other organizations that work very hard to improve outcomes for kids with neuroblastoma. So the Children's Oncology Group is an organization of probably close to 240 institutions working together to run trials, both biology studies and therapeutic trials. Most of the institutions, as you can see on that tiny map, are in North America, so the US and Canada. But there are also institutions from other sites around the world, particularly Australia and New Zealand, and one site in Saudi Arabia that has managed to open some trials and contribute data. Most of the sites are in the United States, and the vast majority of the funding comes from the US National Cancer Institute, primarily the Cancer Therapy Evaluation Program, or CTEP. That becomes very important. The funding source becomes very important because it has implications for the amount of resources that we have in the COG and also the levels of review to which we are subject in the COG. And I'll come back to that in a little bit. The Children's Oncology Group, as much as I and some of my colleagues would like it to be the Children's Neuroblastoma Group, it's actually composed of multiple disease committees, such as the Acute Lymphoblastic Leukemia Committee or the Wilms Tumor Committee, Brain Tumor Committee, and so forth and so forth. So all of the major childhood malignancies are represented in the Children's Oncology Group, and the COG is committed to advancing the care of all of those children, not only children with neuroblastoma. In addition, the COG tries to have a big tent philosophy and includes not just physicians, but also other kinds of professionals who are involved in the care of children with cancer. So that includes nurses, pharmacists, sometimes social workers, epidemiologists, lots of different kinds of people who bring different kinds of expertise to bear. In addition, it's not just medical oncologists who are involved in COG, it's also surgeons and radiation oncologists and others. So COG is, one of its strengths is its diversity, but with that diversity of diseases and also expertise, there are certain challenges that I think are unique to COG. So what does COG do well? COG has the reach and has enough patients and institutions to do really practice-changing clinical trials. So I don't know how many of the people on the webinar are aware of kind of the tidal wave that shook the acute lymphoblastic leukemia world relatively recently, but a Children's Oncology Group study recently showed that blinatumomab, a targeted antibody, really made a huge difference in the care of children with ALL. And it has really been big news across the oncology world. And the COG was able to conduct that study effectively. So that's a real claim to fame. And the same is true in diseases like Hodgkin's lymphoma and certain types of brain tumors. And of course, I think everybody on this call has probably heard of dinutuximab, but the original randomized study that showed the benefit of anti-GD2 antibody therapy, again, in a randomized controlled trial, was conducted by the Children's Oncology Group. So these kinds of large-scale studies are really what COG does particularly well, and it changes how we take care of patients. There's some other things that COG also does well. And so in the neuroblastoma world, there's a partnership, as I mentioned, between surgeons and radiation oncologists and others. But what the COG was able to do very well a number of years ago was led by surgeons, and it involved decreasing the toxicity associated with surgery in very tiny babies with neuroblastoma. And again, this changed the standard of care, because a long time ago, little tiny newborns were having surgery to remove tumors that would have gone away on their own. And so Jed Nocturne and Bob Schamberger spearheaded this effort to just observe these babies, and they do very, very well. So that was an important step forward in our field. Other kinds of studies conducted by the Children's Oncology Group that maybe aren't as much in the eye of parents of children with high-risk neuroblastoma are studies that are conducted for children with non-high-risk disease, like intermediate-risk disease. And it turns out that what the COG has been able to do is use a risk-based therapy and response-based therapy for children with non-high-risk disease in an effort to maintain good outcomes, but cause less toxicity for those children. And it turns out that about half of children diagnosed with neuroblastoma don't have high-risk disease. And so the Children's Oncology Group has the wherewithal to conduct studies that impact our approach to those children as well as those with high-risk disease. Importantly, that because the COG is large and has a lot of institutions and therefore a lot of patients, the COG can also focus on relatively rare subsets of patients who are considered to have high-risk disease, but any single institution won't have enough of them to be able to impact the therapy delivered to those patients. So Naveen Pinto and others put together the data about this relatively rare, I won't get too much in the weeds of the definition of the set of children. But Naveen and his colleagues were able to put together some clinical data with some biologic data to help us make a good choice about how to approach those patients. So these are some of the things that the COG does quite well, which not everybody is aware of. The other thing that COG can do very, very well is to take large amounts of data, analyze it very thoughtfully, and help us think about approaches to newly diagnosed patients and how to classify their risk for disease recurrence. So some of you may wonder, like, how did people figure out that my child had high-risk neuroblastoma versus intermediate-risk neuroblastoma? And it's really a pretty detailed and sometimes laborious process of looking at things like age and stage and the presence or absence of tumor MYC amplification and other biologic features, putting all of those things together, looking at the outcomes of past patients, and then developing algorithms that people in real life can use to best assign therapy. So this was first done a few decades ago in the Children's Oncology Group, but was redone using modern era data back in 2021. And Meredith Irwin, who some of you may know, shown here on this slide, led a whole group to work together to look at the outcomes and come up with these pretty simple to follow, well, at least to me, they're simple to follow, but kind of algorithms that help us assign risk classification and think about how to treat patients most appropriately. So this also came from many years of the COG database, and we will continue to refine the risk classifier as we move forward. But it's important to note, even though there is a published risk classifier developed by the Children's Oncology Group, the use of data does not necessarily imply a dogmatic direction or directive for individual patients or individual providers. So here I've shown you an example of that. So on the risk classifier paper, there are groups of patients, as you can see in the big blue circle, with certain kinds of tumor appearance under the microscope and age and stage of disease. And on the right-hand side of the slide, you can see that some of those patients are designated as having high risk. And those are the data, the outcome data and the biology data and the stage data all point to this designation on the algorithm. However, there are nuances to many, many patients. And as clinicians, we all try to think about those patients as individuals, and their tumors and their location in their body matter a lot. And the variability of how they look under the microscope matters a lot. And so just because an algorithm says that a patient should be treated as high risk, it doesn't necessarily mean to you as a parent of a child in one of those subsets that that's written in stone and that can never be mitigated or never really thought through in a nuanced way. And I say this because I've had a number of patients in recent years since the risk classifier paper was published, where even as an author of that paper, I have realized in discussions with the surgeon or discussions with our lab colleagues that there are nuances to those patients' treatment or those patients' characteristics. And we may be wiser to not jump to high-risk therapy just because the algorithm tells us so, but to really take that patient as an individual and try to understand what might be best for them. So I think it's important for patients and parents and everyone involved to understand that the COG doesn't dictate how a patient is treated. What the COG can do is provide data to support decision-making, but always it's going to be a conversation between the people who are trying to take care of the patient and the family members and everybody involved in the care. So sometimes I get questions from people, patients who may come for a second opinion or something like that, and they say, well, we were told the COG says we must do this. Well, the COG doesn't tell anybody how to treat a patient. The COG just provides data from clinical trials to try to make sense of it all. I know that's kind of nuanced, but just wanted to make that point. To that same point, the COG runs clinical trials to answer pressing questions, and we'll get to what some of those are. There are other organizations that have published standards of care for treatment of patients. I'm more familiar, of course, with North American standards than I am with European standards. But for example, in the United States, the NCCN, the National Comprehensive Cancer Center Network, publishes guidelines for a whole bunch of adult cancers, lung cancer, colon cancer, breast cancer, et cetera. They've only recently shown an interest in taking on guidelines for childhood cancers. And last summer, they published our extensive work to develop NCCN guideline for children with neuroblastoma. This is used by both clinicians and by insurance companies to kind of ease the way towards decision-making and coverage for certain kinds of scans and certain kinds of therapies. That has been very beneficial. I can say in my own practice, if an insurance provider tries to deny something that's in the NCCN guideline, I can then show them the guideline and say, no, this is evidence-based, and the National Cancer Center Comprehensive Network is behind it, and they very quickly agree to pay for it. So, but COG doesn't make these guidelines. COG provides the data that supports this. What does COG do? As I mentioned, it's the generation of data that impacts practice. And I referenced before the ANBL 0032 study, which was really a landmark paradigm shifting trial. As you can see, the data here show in a Kaplan-Meier curve, this is survival on the y-axis, this is time on the x-axis. And these are patients who received dinutuximab during the latter part of their high-risk therapy. These are patients who did not receive dinutuximab. And you can see there's a substantial difference and improvement in outcome based on the use of this anti-GD2 antibody. And this really changed the field. And many thanks to LSU and all of her colleagues who designed and conducted the study. And many thanks to all the parents who were extremely brave to enroll their children on this randomized trial that really changed the game. And COG has the infrastructure to do those kinds of trials. The subsequent trial, large trial in the COG that was published was the ANBL 0532 trial. And many of you are familiar with that. But for those of you who are not, the clinical trial was designed to administer intensive chemotherapy to all the children at the outset, have those patients undergo surgery to remove their primary tumor, and then half of the patients were assigned to 1 round of high-dose chemo with stem cell rescue, and the other patients were assigned to receive 2 rounds, essentially, of that therapy. And the question was, kind of simple conceptually, is more better? Is 1 better or is 2 better? And how do those patients do? And what you can see in the outcome data in just the numbers rather than the graph this time was that there was a significant improvement in event-free survival in patients who got 2 rounds of this high-dose chemo with stem cell rescue rather than 1. And so that then became the standard of care in North America. It doesn't mean that people have to slavishly follow that guideline, but these are the data, and this was the trial that supported that. I've had a number of patients in my own practice who, for whatever reason, could not undergo high-dose chemo with stem cell rescue 1 time, much less 2 times. So one of my patients was born prematurely and has some significant challenges related to that and is rather a fragile little child. I'm not going to put that patient through 2 back-to-back rounds of high-dose chemo with stem cell rescue just because the ANBL 0532 data showed an improvement when that child's not going to be able to handle it. So again, the idea is providing the data, helping people make good decisions, but not necessarily dictating every nuance of care. Going forward, again, the COG has been able to provide data to guide clinicians in how to think about the relapsed and refractory setting. So the two trials I just showed you previously were relevant to patients in the newly diagnosed upfront setting. But a number of years ago, we conducted the ANBL 1221 trial, which used a chemotherapy backbone, low-dose chemotherapy backbone of irinotecan and temozolomide, and then had patients randomized to receive either the mTOR inhibitor temsirolimus or the GD2-directed antibody dinutuximab that we just spoke about. Half the patients got one, half the patients got the other, and then we looked at response rate to determine which one really was the winner. And you can see here, far and away, the winner very clearly was the irinotecan, temozolomide, and dinutuximab arm. And you can see the response rate here exceeds 40%, which we had previously never seen in patients with relapsed neuroblastoma. It was really quite shocking. And that really changed the paradigm and changed our thinking about how we would approach patients with relapsed and refractory disease. So again, just having a broad reach, being able to conduct a randomized trial was really, really important. The other thing that COG is able to do is to generate, because of these larger scale studies, we're able to generate biology data that can help to move the field forward. So many of you may be familiar with one of the aberrations in a gene called ALK, and that has been shown to have important implications both for how we think about children with ALK-driven cancers and potentially implications for therapy as well. So this paper from Cancer Cell was really an important one in the field, and the specimens that these investigators were able to study came from the COG biobank. And so without having that vast wealth of tumor tissue, these folks would not have been able to do what they did and really make an impact on the field. This is, I could show many, many papers, but this other group and others as well have been able to define tumor characteristics that may be very important in shaping our thinking and leading to new therapies for children with neuroblastoma. And again, these and many other papers came from work that was made possible by the biobank. In addition, COG has a whole wealth of cell lines that were generated based on the willingness of parents to allow biospecimens to be collected from their patients. And those cell lines can be used for Petri dish, essentially, experiments. Also, Dr. Pat Reynolds, whose name is here, has started a really extensive mouse model program to generate living models of neuroblastoma, and those are publicly available. He does a great job maintaining the bank of these models and is very, very generous and goes out of his way to share them with other investigators around the country and around the world. So those are the kinds of resources that I think COG is able to provide. Other things that COG does well on that same theme. So last time I spoke with this group, I mentioned the ANBL 1531 trial, which is a large randomized phase 3 trial that closed just a couple years ago, and more than 700 patients were enrolled. So it was answering a question related to the initial therapy of patients, whether or not MIBG in the frontline setting improves outcome. And I don't have the answer to that yet. But importantly, we really thought ahead about the whole raft of biology studies that we would be interested in doing in order to learn more about the biology of neuroblastoma and lay the groundwork for new therapies. And this chart just gives you an example of the kind of specimens that those patients and families very kindly agreed to supply, and some of the work that will be done through the context of uniform therapy on a clinical trial. COG is also very interested in late effects, And this is where the strength of having a diverse membership comes in, because there are oncologists, there are endocrinologists, there are infectious disease people and pulmonologists and audiologists that are part of COG and can really lend their expertise to the study of late effects in survivors of children with high-risk neuroblastoma. Lisa Diller and Tara Henderson ran this trial called the LEARN study, Late Effects After High-Risk Neuroblastoma Therapy. And they've really pushed the field to think about what kind of toxicities people experience years after therapy. And we're making some changes in how we think about mitigation of these late effects. And again, that's the strength of having a large patient population and a diverse group of investigators. So just to summarize, I do think there's a lot that COG can do quite well. In addition to the big, questions that we put in lights and the primary aims of the trials, we're also able to do secondary analyses and looking at small, often molecularly defined subgroups of patients because the trials are large. We can look at new biomarkers as well as the old ones. We can do retrospective analyses of imaging studies and try to approve how we assess disease response. Surgeons are very, very active in the neuroblastoma committee, as are the radiation oncologists, so we are able to answer questions related to what they do. And as I mentioned, we can also look at supportive care studies and then extended long-term outcome to see if responses and effects on survival are maintained. In addition, we're really committed to training the next generation of investigators. So we work very hard in the COG to get young people involved in retrospective projects and in trials because they're the ones who are going to be leading neuroblastoma investigations long after those of us who are doing this currently are out of the picture. But I really want to emphasize COG is far from perfect. There are lots of challenges. And I think maybe the best way to conceptualize COG is as this gigantic, very slow moving ship on the ocean. It can make really big changes and can alter the path forward or the route forward on the ocean, but it's not nimble. COG is not nimble. I have to emphasize that. It's not a tugboat. And I think if you conceptualize it in that way, you realize that there's a whole host of organizations and institutions that are needed to really make things go. And so there have to be institutions that do things differently or smaller organizations that do things differently and pull the big ocean liner into new directions that it couldn't otherwise have gone. But you can't expect the tugboat to do the work that a big gigantic ocean liner does, and you can't expect the ocean liner to do the work that the tugboat does. So I think of them as complementary. What's challenging for COG is that it's a big organization. There are many levels of oversight, and the review systems for COG proposals of any sort are very, very cumbersome. From the level of not just neuroblastoma committee leadership, but also overall COG leadership, to the National Cancer Institute review, all the regulatory governmental reviews, as well as institutional reviews. It just takes a long time to move things forward. Whereas if you're running an institutional study, you don't have so many levels and faceless, nameless reviewers. You have your own systems and things can move much more quickly. The other issue, as I mentioned earlier, is that COG is largely funded by the National Cancer Institute, and it is a resource-constrained organization. The funding for COG has been flat in the last several years in the face of pretty considerable inflation. So it's kind of operating with a net lack of funding for the last several years, and looking to next year and the following year, the budget is being cut considerably. So the organization is resource constrained, and then you have to think about the participating sites. In the post-pandemic world, there was a big shortage of data managers and nurses and all the people who make things go at the individual treating institution. And it's those institutions that help patients enroll on studies and submit the data. So there are a lot of resource constraints at various levels that make it harder for COG to do its good work. The other thing, as I said, I would like to think of COG as a neuroblastoma only organization, but it's really not. And so there are other really important pediatric cancers for which survival rates are still very problematic. And so there are competing demands for patients with Ewing sarcoma or rhabdomyosarcoma or brain tumors. And we just have to keep in mind that COG is trying to run trials for all of those patients. So I'll stop there, but I just wanted to frame, or stop with that part of the talk there, but I just wanted to frame everybody's thinking about what COG is, what it has the potential to do, and what's really hard for it to do. Because I think we just have to be honest about what its role in the ecosystem really is. I mentioned the last time I spoke, our current high-risk trial has the catchy name of ANBL 2131. And that is a study that is designed to ask the question about whether the addition of GD2 targeted antibody therapy improves outcome in patients with newly diagnosed high-risk neuroblastoma. So the standard therapy on this trial, every patient who enrolls gets an initial cycle of chemotherapy, and then they get 3 additional cycles of chemotherapy, traditionally surgery after cycle 4, a 5th cycle of chemotherapy, and then those who have a good response go on to standard high-dose chemo with stem cell rescue, as per the study I showed you earlier, ANBL 0532. Those who don't have such a good response can get the kind of therapy that we developed in ANBL 1221, which is irinotecan, temozolomide, and dinutuximab, and then move back onto the main road, if you will, off of the side road, and continue on through therapy. All of the patients then go on and receive radiation and dinutuximab in the latter part of therapy, according to the ANBL 0032 study. But this is where the action is, because this arm looks different from this arm. The D stands for dinutuximab, which is an antibody directed at a molecule on the surface of neuroblastoma cells called GD2. I'm happy to talk about the biochemistry of that or GD2 as a target if people are interested. But the bottom line is that these patients get the same chemotherapy and surgery, but they get the addition of an antibody directed at a molecule on the surface of neuroblastoma cells. I don't get to decide who goes on which arm. Parents don't get to decide, because it really wouldn't be fair if we could pick and choose who gets which arm. So this is randomized, so it's randomly assigned by a computer. So half the patients get the dinutuximab and half the patients don't. And the branching point here is the same as up above. So patients who have a good response to therapy move on to all the rest of the treatment. Patients who don't have such a good response could go on and get the irinotecan, temozolomide, dinutuximab. Whether that's wise or not is up to discussion, but this is the outline of that trial. This study opened in April of 2024, and accrual has been good. Patients are enrolling on the trial. And again, all thanks to the parents of patients who are kind of in shock when their child is first diagnosed and they're approached about a clinical trial, and they're brave enough to say, I'm willing to enroll mainly in the hope that we learn something that can benefit kids in the future. And that's a really brave thing to do. I'll be happy to take any questions like at the end about ANBL 2131. But just so you know where we're going, once we have completed accrual to ANBL 2131, it takes a little bit of time for the outcomes to be understood. Like if you just barely finished your therapy, we won't know really whether you benefited from that treatment or not until some time goes by and we see whether patients develop a relapse or not. And then once the data are what we call mature, then we can report out, yeah, MIBG early on in therapy helped prevent relapse, or dinutuximab early in therapy helped to prevent relapse. So we get into a little bit of a problem of leapfrogging, because at this moment, while 2131 is happening, we don't know if MIBG improved outcome on 1531. We'll know that in a little less than 2 years from now. And the same thing will happen. We'll finish ANBL 2131 and then have to wait for the results to be able to tell you whether early inclusion of dinutuximab is good or not. In the meantime, we don't want to sit around for a decade, waiting for these answers. So we've already started to plan our future high-risk trial, which by now you're familiar with these shapes. That includes chemotherapy as initial treatment. Patients with a good response get to proceed on. Patients who don't have such a good response can get irinotecan, temozolomide, and dinutuximab. But the key randomization happens here for patients who have a good response to therapy. We're asking the question, in the era of chemoimmunotherapy, do we still need to do tandem transplant for children with high-risk neuroblastoma? And the story of this is a little bit historical. So back when ANBL 0532, the one that I showed you before, which is the 1 transplant versus 2 transplants, was developed, immunotherapy was still in its infancy, and chemoimmunotherapy really wasn't even on the scene yet. And so the question that was asked in ANBL 0532 was essentially whether more is better. And we got the answer to that. And that was a good answer for the time. But then chemoimmunotherapy came along and really changed everything. And the question that's really important to be asked now is that now we have this new tool in our toolbox. Do we still have to be doing this old stuff? And I actually don't know the answer to that. There's very interesting data and somewhat promising data by Sloan Kettering and others who have said, it seems like maybe we don't need transplant anymore. And their data are very intriguing. But the only way to really know for sure if you still need transplant or not is to actually ask the question and not compare it to historical controls from a long time ago, because lots of things change over time. So if you ask a question in 2025, does this patient population who doesn't get transplant do better than patients who were treated a decade ago? Well, so many things have changed. So there's some issues around historical controls. But if you really want to get the answer to the question in a way that will convince everyone, you do a randomized study, half the patients get the standard tandem transplant, half the patients get chemoimmunotherapy, and then you can say with confidence to parents of newly diagnosed patients, hey, we studied this in the most rigorous way, and we don't need transplant anymore. Or, gosh, we really wanted to get rid of transplant, but unfortunately the data are what they are, and we're not able to do that. Or you say, hey, we had this large cohort of patients, we were able to do some subset analyses, and what we discovered is patients with this profile, XYZ, benefit from transplant, and this cohort of patients with ABCD do not benefit from transplant, and then be able to be more sophisticated in how we think about all of this. So this is our plan, and I think the parent community has been very much kind of the instigator of moving this forward as quickly as possible. That was based on this publication by Nick Bird and others, and also a very beautiful piece written by Leona Knox that was in this same issue of Pediatric Blood and Cancer. But the parents really pushed to address this question, and we heard them and said, we're going to undertake this randomized trial. We have a concept put together. I really like it. I think it's good. I think others really like it. We've previewed it with some of the people who will review it. And there's some nuances to it, but I do think there's a lot of excitement in the field about answering this question. This trial can't open until ANBL 2131 is finished. And so keep your ears tuned. That's not going to happen right away, but we're working towards that. In addition, the opportunity to run a large randomized trial provides the opportunity to try to concurrently study rare subsets of patients. So I'm not going to go into the weeds of what every subset consists of, but let's just say that there are specific groups of patients that are very rare, but very important, who may be currently overtreated or undertreated based on the way we do risk stratification currently. And the ANBL 2431 trial will give us the opportunity to at least collect data on different ways to treat those patients, to try to perhaps decrease hearing loss or other kinds of side effects that we're currently incurring in those patients. We in the COG are also very much looking forward to studying new combinations in the relapse setting. So I mentioned the ANBL 1221 study and the importance of chemoimmunotherapy. But as I've shown before, there certainly are patients whose tumor starts like this, as a patient with disease that wasn't really responding to treatment, and after treatment just progressed no matter what we did with chemoimmunotherapy and look like the right-hand panel afterwards. So we're working very hard to try to find ways to improve the effect of chemoimmunotherapy, potentially with a different additional agents like immune response modifiers, maybe different antibodies other than dinutuximab, or smarter selection of patients who are most likely to benefit from the use of this kind of approach, so better biomarkers as well. We also in the COG are very interested in preventing hearing loss, and so we have a new proposal to try to use another drug to try to decrease hearing loss. We're trying to image tumors better, so hopefully within the coming year we'll have a new imaging study open to improve our ability to make good decisions. We're also doing a large-scale analysis of liquid biopsy approaches that should help us make good decisions in the future. And we're trying to, as I said, develop new biomarkers to try to identify the patients who are most likely to respond to treatment. So the other thing that COG is very much interested in is collaborating with our colleagues from across the ocean and around the world. My counterpart, many of you know, Lucas Moreno, is a lovely human being, and the leadership of both groups is very interested in working together to avoid redoing the same studies. And also to collect data that we can then share and improve both the response criteria and the databases that we all use. Also, we as a bargaining team can have more potentially impact with the big pharma companies and small biotech firms to try to induce them to do studies in neuroblastoma. In the big picture, we'd love to do collaborative trials, not just across the ocean, but around the world. But the infrastructure needs are pretty complicated. I guess I didn't really understand this until I started to try to do it. But there are a lot of legal implications and a lot of database implications, and we're all kind of stuck in our ways. And so there's some precedents that need to be overcome as we all compromise to try to work together. But that's a major priority for us. So I'd like to open it up for questions and answers. I just wanted to show you some of the folks who do the work. There are many, many more than this, but just to give you the flavor of who we are, and I hope you've learned a little bit about what we do currently and what we would love to do. Thank you so much. So I guess, should I start with the Q&A? Is that,
Yeah.
Einat, is that next?
Yes.
Okay. Okay. So we understand it's difficult to draw conclusions early after the start of a trial. Are there metrics to evaluate early on whether a certain therapy is more beneficial than others among the randomized group? For example, response rate. It seems we have to wait decades for results that become outdated when they eventually come out. That's such a great point, and it's so true. So we have been in dialogue with a number of regulatory agencies, including the FDA and the EMA, to try to analyze early response as a proxy for overall outcome. And we presented a proposal for that. The regulators were not willing to accept that, at least at this point in time. And the drug companies therefore follow the lead of the regulators because they can't get their drug approved if the FDA won't accept the endpoint. So I'm with you. I hate sitting around waiting for results of trials. It's just so frustrating. But right now, early response was not accepted as an endpoint. That being said, I really think that liquid biopsy may be a path forward. And one of the reasons that we undertook this large scale study of liquid biopsy as part of the ANBL 1531 trial was to try to generate an early predictor of overall outcome so we would know sooner than later whether something's working. So agree 100% on that. Are there any COG plans for maintenance therapy after frontline CR? Yes, as a matter of fact. Also a great question. So as many of you know, DFMO, otherwise known as eflornithine, was studied in a consortium trial, the Beat Childhood Cancer Consortium trial. And the data from that single arm study were compared with historical data from the ANBL 0032 trial. That group did a very nice job thinking about the statistical analyses and how to compare the groups. The original trial of DFMO as a maintenance therapy was not a randomized trial. And so it's very difficult to have a perfect control when you didn't have half the patients get the drug and half the patients not. Trying to construct a similar kind of control after the fact is really, really hard. I think they did as good a job as anybody could possibly do. There's some problems with that control, like they are with any other non-contemporaneous control. And so many of us just aren't sure whether DFMO as a maintenance therapy makes a difference or not. The FDA in its analysis of the data thought that it did, and they gave approval in December of 2023 for DFMO as continuation therapy. The issue for COG is that there may be differential uptake of the use of DFMO. So some families may be very gung-ho about wanting to get DFMO since it is FDA approved. And there are other families that are just like, no, I need to be done. Like, I don't want to still be on neuroblastoma therapy for 2 more years and have to get labs checked and have to come to clinic. Like, I'm done. And that could be different based on a number of factors that are hard to quantify. And so going forward, the COG has put up a proposal to include DFMO across the board on both arms of 2131, just so that we don't mess up our ability to ask the main question, which is about dinutuximab during induction. So the addition of DFMO across the board shouldn't necessarily be interpreted as, yes, COG is advocating for the use of DFMO. I think many of us in COG just still aren't 100% sure because of that issue of the historical control. But we feel that as a research organization, we have to do the very best we can not to mess up our ability to answer the main question. So that was a long answer to a short question, but the bottom line is there will be a what we call continuation phase once the amendment to ANBL 2131 has gone through. What about the combination of dinutuximab with nivolumab? That's a great question. The use of checkpoint inhibitor therapy plus dinutuximab and MIBG is being studied in the minivan trial. And so we'll be very interested in those results. It'll be hard to interpret just the checkpoint inhibitor plus the dinutuximab, but we'll take a look for sure. What about refreshing antibody therapy after 2 years of remission? Another really thoughtful, excellent question that nobody's answered yet. So I don't know about that. Besides MYC and ALK, are other mutations being studied like ATRX, BARD1, et cetera? So yes, the answer to that is yes. There's a very extensive genomics effort that was incorporated into ANBL 1531. And we have some of the early results from that, which I feel really excited about. we have to be careful in talking about these different mutations because some of them are related to predisposition, like BARD1, and that's found in the normal cells in the body, versus changes in ATRX, which sometimes are found in DNA sequence and sometimes are related to expression based on RNA studies. So it is quite complicated, but we've fortunately been able to partner with some of the leading experts in genomics and transcriptomics. So stay tuned. We're going to have some really cool data from ANBL 1531. Next question. Is COG considering haploidentical transplant in the future versus tandem stem cell rescue, or is the goal to move away from transplant completely? Interesting. So some of the German investigators are really excited about haplotransplant actually in second remission, but we can't answer all the questions with like in a randomized study with sufficient power. So COG has really prioritized addressing the transplant versus chemoimmunotherapy question, at least for our next trial, but we'll be listening very closely to the experience of the German investigators. And, if chemoimmunotherapy cannot replace current approaches to transplant, we'll definitely be in conversations with the German folks to see about the whole haplo story. So stay tuned. Is it true that MYC amplification is no longer seen as a prognostic factor and in fact may be a good marker for those patients who respond well in terms of OS? That's a great question. So MYC is most powerful in thinking about risk stratification. So if you have a child who has localized disease, for example, a young child, and the tumor comes out to be MYC amplified, that changes the patient from being considered to have intermediate risk disease to high risk disease. And it's still a very important prognostic factor in neuroblastoma. However, if a child is over 18 months of age and has metastatic disease, regardless of MYC status, they already have high risk disease. So the prognostic impact of MYC amplification sort of gets lost in the context of just that group of patients with high risk disease. It doesn't make you extra high risk or less high risk or something like that, but it can move you from being intermediate risk to high risk. So it's still super, super important. There are a lot of studies trying to understand how should we think about the sort of heterogeneous group of patients who are considered high risk in terms of treatment. So might there be therapies that work better in patients with MYC amplified disease versus non-amplified disease within the high risk group? So I think probably a decade from now, there may be. So I don't think looking at MYC is going to go away, but you are correct in that once you're already high risk, it doesn't change within the high risk group. Did I answer them all?
Yes, you did a great job. Thank you so much for this interesting and important conversation. I think all of us have learned a lot from your insights and experience. Thank you very much for that. One question that was there that regarding the recording of this webinar, so we will send everyone who registered the link for the recording. And also, as I mentioned earlier, we have a monthly program. So the next one will be on the 5th, February 5th. It will be with Dr. Susan Cohen. And the next one will be regarding the CAR-T clinical trial with Dr. Francesca Del Buffalo. So please stay tuned. And thank you everyone for attending this session. We really appreciate it. Have a great day.
Thank you. Bye.
Thank you. Bye-bye.